several hundred genes on them, whereas a panel that kind of represents like California may only have about 15, 20, 30 genes on them. So now, if we want to do exome sequencing, we're going to look for Carrie somewhere on the planet. And that is what exome sequencing pretty much is. We know she's somewhere. We know she doesn't live on Mars. She's on planet Earth. She doesn't live in the ocean, which would be like the intronic regions. She's somewhere on this planet. But we have to go through every single state to find her. And that's why exome sequencing is expensive and it's time consuming, because it's just a very lengthy process versus maybe a panel test where we're looking at just one country. In whole genome sequencing, Carrie is somewhere in the universe. And hopefully she's on planet Earth, but she could be on Mars or Jupiter. And so that's, and kind of what we heard before is that we know a lot about planet Earth, and we maybe know a little bit more about the moon and the sun, but we really don't know a lot yet about all the other planets, if you think about it compared to planet Earth. And that's really exactly what whole genome is. And that's why it's so hard to utilize whole genome sequencing in a clinical setting. So what's an incidental finding? So we're doing sequencing. We're looking for Carrie. We think she's in the United States. We do the testing. She may be in the United States, but she may also be in Australia. We never would have thought she was in Australia, right? So it may mean that we find her in Australia and we find somebody else in the United States. And that means that you could do whole exome sequencing or even a panel test thinking one thing, thinking you're going to find one thing, but you actually find something totally different. And perhaps it's not even related to the same disease. So this could be, for example, you have a child who presents with a very suspicious cardiac disorder you think has a genetic component, and you run the test. Perhaps the child is positive for maybe long QT or a cardiomyopathy, but then we also find the child carries a genetic mutation in a gene that predisposes him or her to cancer. And maybe that cancer won't be coming until they're 30 or 40 or 50, but now we found this information. And what do you do with it? And so that's where the issue has arisen in the genetics community. So just to clarify really quick, incidental findings and secondary findings are kind of the same thing. People interchange the words, so if you hear them, it means relatively the same thing. And the American Society of Human Genetics in 2013 decided to get very much involved in this. We have the great fortune at Invitae to have one of the driving forces behind incidental findings is now Robert Nussbaum. He's our chief medical officer. And so in the definition that the HAG put out, they decided to say that an incidental finding results from deliberate, okay, this is important, deliberate search for pathogenic or likely pathogenic alterations or mutations in genes that are not apparently relevant to diagnostic indication for which the sequencing test was ordered. So again, if you have the child who's presenting with a cardiac syndrome clinically, but you find something in a BRCA gene, the child wasn't presenting for necessarily personal family history of cancer. That's something we found through deliberate sequencing because we chose to pursue exome sequencing, but now we found this other piece of information. And so the HX said, in clinical exome and genomic sequencing, there's the potential for recognizing and reporting of incidental or secondary findings unrelated to the indication for ordering the sequencing, but of medical value to patient care. So this is important too, because what they decided was, you know, the big issue is, what do we do if we find this? You know, they're here because they're worried about cardiac syndrome or a rare disease, but now we're finding something else. Do we talk to the family about it? Do we do something about it? At what point do we inform the family or not? And so that was where all the great debate came from. So one of the things they did is they created 5 recommendations, first for laboratories and clinicians to follow. Because number one, it's the clinical labs who find the incidental finding in the first place. The clinician just sends the blood to a lab like ours, and we do the sequencing, and then all of a sudden we're like, oh my gosh, we found something else. So now we have this information. So number one, it starts with, what do we do with it? First recommendation is that these mutations found in the genes should be part of a minimal list. So what they decided to do was they created a list of 56 genes, and that list is continually growing, that have disorders in them that can be medically actionable, which means you can actually put guidelines or treatments into place to prevent disease from happening or onset, or at least give families enough information that there can be some proactive measures taken. And so with that, they decided these were a list of genes that they recommend laboratories report back to families, and to clinicians, obviously. They said to seek and report only the types of mutations within these genes that have been delineated in the minimum list. So it means also like really stick to the minimum list of 56, and also really look at mutations that are positive, not ones that are uncertain, because that's too much psychologically, emotionally for clinicians and families to deal with. When you're looking for perhaps a cardiac condition, and then all of a sudden you're like, well, there's this other finding in this other gene, but we don't really know what it means. It's just not medically actionable because you don't even know what to do with it. So they put a little bit of boundaries around this so that it could be somewhat clear and give people somewhat of a guideline on how to manage these complicated situations. They obviously said it's important for clinicians and the clinical team to provide comprehensive pre- and post-test counseling to the patient. And this is something I think a lot of laboratories in general would also recommend, as well as the American Society of Human Genetics, is that pre- and post-test counseling, informed consent, is incredibly important when you're pursuing genetic testing because of the fact that you could uncover things you weren't expecting. Recommendation 4 was these to reflect limitations of current technology and therefore focus on disorders that are caused by point mutations, small insertions, deletions, not those primarily caused by structural variants, repeat expansions, or copy number variations. So what this means is that, and it's geared mostly towards panel testing and exome, where you have just the way that technology is with next-gen sequencing, there are limitations. So an exome, for example, would not be able to find a complete rearrangement on a chromosome. The technology just can't pick that up. And often, if you're having complete rearrangements on chromosomes, there are many, many genes, sometimes hundreds of genes involved in those. And so it's not really falling into the category of a secondary finding per se. And so what they're trying to say is that this is really when you're doing full sequencing. If you happen to find something else using that same sequencing technology, that is what the guidelines are applying to. That could change as technology changes, but for right now, that's pretty much reflective of what our technology is. And then finally, recommends that the ACMG, together with content experts and other professional organizations, refine and update this list annually. And this is because, as we've heard many times throughout the conference already, is genetics is changing rapidly. So every year, we're having new genes that are being associated with disease. There are new guidelines, new treatments that are becoming available. So as we know this information and we're learning about this, we should be updating that 56. And already, since the guidelines came out in 2013, there have been other genes that are now considered actionable that are being added to expanded lists. So the ethical debate, some people live in the camp where they feel that secondary findings is a gift. They think that, wow, I came for this. I also found this out. They gave me a gift. I'm only 25, and I have now the ability to put medical processes into place so that I can perhaps prevent an onset of cancer. Some people feel like it's a curse. Maybe it's too much information. I didn't want that information. I'm so concerned about this one thing, and now I'm finding something else out on top of that. It's too much for our family to handle. So that's a little bit of a debate, too. And so we're always having to think in genetic testing in general about our 4 major principles, which is autonomy, a patient's choice, patient's right to say, yes, I want this, no, I don't want this, and giving them the ultimate power in that. Beneficence and non-maleficence, which is just making sure that we're not doing any harm, that the benefits are always outweighing the risks, and justice, that it's accessible to everybody, and that it's fair, and that it's not just for a select few. Some people criticize incidental findings and they call it opportunistic. However, others will argue opportunistic screening has existed in medicine for a long time. If you go to have a chest x-ray, radiologists will take a look at it. They're looking at the left part of the lung. They don't see anything, but there's a big mass on the right side. They're not ignoring that. Even though the test may have said, we want to look at the left side of the lung, they cannot ignore the fact that there may be a tumor on the right side because that's putting the person's life in jeopardy. So some people say, well, we've been doing this in medicine for a long time. Screening, very much an opportunistic, right? We've heard about screening, and these can be cost savings. These can be used for newborn screening. So there are the opportunity for interventions, and also by having this information, we can really employ genetic counseling into the process to, again, uphold autonomy and some of the ethical principles that guide testing in the first place. And the National Society of Genetic Counselors has also put out a position statement that they actually support the return of these incidental findings, so they feel that the benefit of returning them to patients outweighs the risk. But they have some specific points that they feel that clinicians should follow. And that means that there should be a plan. It shouldn't just be like, oh, hey, we were testing you for this, but guess what? We found something else. It should be like, you could potentially have the risk of finding something else, and we want you to know that ahead of time. Some labs will even give families the opportunity to opt out, and they say, you know what, it's just too much for us, we can't handle it. We'll check a box and say we just don't want it. Second, they want pre-test and post-test counseling, clear expectations. Providers should also help provide access to specialty care. So if you find that you have now a mutation in a cancer gene or cardiac gene, getting that referral to the person who can now implement some of those guidelines and really give you the proper treatments that you need so that you can be a little bit proactive. And obviously, we're biased. We always say genetic counselors should be involved. And there's been some data to support this now. So 2013, some of these guidelines came out. 2014, we started to see some papers. So originally, the American Society of Human Genetics said, we estimate an incidental finding, meaning someone goes through exome or next-gen sequencing, probably about 1% of the population is actually going to have a second hit of something else going on. But around 2014, they started collecting the data and found that it's actually 3 to 5% of patients. And this is really only patients, these are patients who are being ascertained for something else, which means there are probably many more of us walking around who have something else going on that we don't know about. Another paper in 2014 from a team in UCLA said that the diagnostic rate for both primary findings as well as secondary findings increased when trios were done. So it's important because you want to make sure you have as much information as possible to identify what's truly an incidental finding and what might be just a variant that may or may not necessarily be associated with disease. So when you're doing exome sequencing, especially for both primary and secondary findings, it's important to have as many people involved in the family tested as possible. It increases the detection rate. And then they looked at patients. What did patients say? So, a lot of clinicians said, oh my gosh, my patients aren't going to want this. This is going to be too much information for them. But actually, when they looked at and surveyed patients, a paper in end of 2013, when the debate was really hot, came out and said about 93.5% of patients would actually like to receive this information. And so I think that goes because a lot of patients are learning to take the information and want to be empowered with it to make their own guided healthcare decisions. And then in 2014, there was a paper by Baylor that also agreed and said even more, 97% chose to receive any incidental findings that would come back from sequencing. And so then in 2015, we have a new paper that just surfaced that I love. It's from the American Society of Human Genetics. And they were saying that 1995 was the last time this paper was originally written, so it's been 20 years. Which means a lot has changed in 20 years, and a lot has changed in 4 years, so much less 20. So they said, okay, it's time to revise. We need some new guidelines, especially because a lot of exomes and whole genomes are being performed on children. So what does this mean for diagnosis of rare disease, especially in the pediatric population? So first of all, they talked about just the technology itself, and they said, when clinically indicated, the scope of genetic testing should be limited to single gene analysis and targeted panels based on clinical presentation. So if you have a child who's presenting with epilepsy, they want you to either start with a gene that you think may be the cause of that particular epilepsy. So if it's Dravet, you would think maybe SCN1A. If it's a little bit Dravet-like, but there are other features, perhaps just doing an epilepsy panel to start with. And then if it's negative, that's when they say it's appropriate to move to more limited genetic testing. If it's negative, and move to a genome-wide sequencing, which would be exome. And then they said, this is verbatim the statement from ASHG, genome scale sequencing creates a tension between the need to generate a comprehensive analysis of an individual's genome to address a clinical challenge and the need to limit problems created by a wealth of data, including secondary findings. And I think that's just ultimately really naming the ongoing issue. Is more information better? Is it not? And that's the debate in a nutshell. And then finally, just children's and adolescents in general, as far as who should be disclosing the information. So they feel that clinicians disclose the information to parents and guardians only when the information has clear clinical utility for the child and his or her family members. So again, it goes back to medical actionability. There should be that robust informed consent process. So we're hearing this over and over again from a variety of different genetics groups. And it should be considered the same for both somatic and germline testing. And this is a nuance I won't get into here, but what they're saying is if you're doing somatic-based testing for children for cancer disorders or germline testing, these guidelines apply to both. And this, I thought, was probably one of the most robust and somewhat gutsy statements that I've seen the ASHG make in a long time, which is so parents should be able to decline this testing. So what they're saying is that children have a limited amount of autonomy because of their age and sometimes because of their condition. So parents often make the medical decisions. And so parents have the right to make the decision whether the child were to receive secondary findings. And that can be really important, especially if children are getting tested for cancer predisposition genes that may not have an age of onset until they're much older. However, when there is strong evidence that a secondary finding has urgent or serious implication for a child's health or welfare, and effective action can be taken to mitigate that threat, the American Society of Human Genetics recommends that the clinician communicate these findings to the parents or guardians, regardless of the general preferences stated by the parents regarding this finding. So it's actually giving a little bit more power now to the clinician, whereas before we were always very protective. But now we're saying, you know, if the clinician is truly feeling that this is something that's very actionable and has impact on the child's life, that clinician has the right, per the ASHG statement, to then disclose that information to the parents. So it's, again, it adds a little bit extra layer. And obviously research is another area where you can find secondary findings. It's a little bit different. A lot of times the information needs to be then verified in a CLIA lab because it can't be part of, you know, sort of the true medical record unless it's been validated by a CLIA lab. But the research findings can also find, you know, primary as well as secondary findings. And then they just say that everything needs to follow an IRB-approved plan of action that manages incidental findings, so that should be a part of the structure of the protocol of the research before the testing takes place. And everything really just has to be ethically acceptable. And so people said, well, you know, what do we do with this? Like, is this going to cause problems? Are families and children going to suffer emotionally by having this extra information? But actually, the data shows that there's no significant evidence of psychosocial harm in children, and that the baseline uncertainty, not knowing about risk status, can cause actually potentially more psychosocial distress than knowing. So in general, I think it goes back to just that feeling of having more information. And I see this often in the pediatric setting. Having more information can often be more empowering, and for the most part, not having the information can actually be more harmful. So we're moving away from diagnosis, doing a little bit more preventive. You know, we heard today about carrier screening. It's kind of the same concept. You know, if you can do this testing and think forward about this, how that could change the medical system, how it could change healthcare for individuals. We're looking at, you know, all of this testing is playing a role in pharmacogenomics, personalized medicine, targeted medicine, and it's kind of driving management guidelines, because now it's one thing to get a diagnosis and to find the genetic cause of a disorder, but now you have to figure out what do you do with that information, and how can we actually take it to the next level where we can get better cures and treatments and put some action where the mutation is. And then obviously, as we've heard more many, many times today, data sharing and collaboration opportunities are super important. Yeah, okay. So thank you. Did you have it? So that's, the gist of incidental findings. It's an ongoing debate. And as we continue to see our technology improve, the cost going down, the accessibility for families, it's going to change the way in which information is given to patients. And the debate will continue because there will always be something else that people have concerns about. But I think in general, it definitely is we're in the middle of a paradigm shift, and I think that's going to impact the rare disease community, especially as more and more patients are being sequenced through next generation sequencing technologies. Are there any questions?
So with these incidental findings, if you have a family of DNA sent in for whole exome sequencing, do you get incidental findings on all three individuals or just the child?
So it depends a little bit on the laboratory and how it's set up. Often, so for example, if you're doing an exome sequencing with a lab, and they're just doing a trio, and only the trio is being sequenced, then obviously we're going to have just the information on those three. Sometimes families will do family studies where maybe there's a finding and they don't know if it's pathogenic or not, so they'll start bringing in other relatives to test them as well to see if it's segregating. And when that happens, you can then find the incidental finding in other relatives. Usually that's where that plan of action comes into place. Every lab's policy is slightly different, what gets reported out. ASHAG says that theoretically it should be reported out to everybody who's at risk. But how it gets reported out and the process in which that takes place is very tricky, because if I'm a laboratory and I receive, Carrie's DNA and she's now at risk for something, and her sister is also, but they haven't spoken in 20 years, I can't just go to her sister now. I've got to have a lot of those documents in place. So it gets a little tricky. And that's why it's really important to have joint counseling involved.
Is it worthwhile if a patient, if we suspect that there's a link, passing it on to the doctors? I know in our situation, we've got one recessive and the other two have the same syndrome I have. All three of them on spectrum. So I passed along to the doctor, hey guys, this is their link.
So I think anytime anybody presents with a clinical presentation that looks like it could be a syndrome, having that conversation with your physician, maybe being...
We're very suspicious that the autism is coming from syndrome that's called family.
So you're saying...
Are you talking the symptom?
Is it worthwhile if you think something else is going on because of the syndrome, passing it along to your doctor and saying, hey, can you realize?
Is autism part of your syndrome?
We don't know.
Okay, so you're trying to determine if autism is part of your syndrome.
Is it worthwhile passing along to your doctor and think, hey, there's a link to the syndrome?
I think it's always important to give back as much information to your doctor as you can. Whether or not they're going to be able to necessarily do something with it will depend on each individual case. It could go into research.
But there are certain things that just seem odd that fall through.
Yeah. Well, I think that goes back to the whole data sharing component.
Exactly. I was just going to say, that's, as a community leader in your rare disease community, it's really important to start talking and getting that information, the data collecting, even if it's in an informal way. Because, for example, in our personal situation, in my daughter's disorder, they had no information, there was no physical connection. Well, we now found out all these kids looking at their pictures had the same physical commonality, which now helps detect other kids in the future.
Yeah, and even though maybe you've had testing and something was not reported back to you as an incidental finding per se, or even part of your primary finding, the way things are growing and the information that's being pulled together, we might find something 2, 3, 4 years from now, and sometimes labs will re-report that out if something has changed to a family. Sometimes the families and the doctors have to go back to the lab and say, hey, there's some new papers that have come out, can you double check? It's a process, because it's limited right now.
So it's good to keep the conversation.
Absolutely. Always. And I think that, both keep the conversation going, both with your clinician and your genetic counselor if you have one, as well as with the advocacy groups, because a lot of times the advocacy groups are really on top of which genes are coming out, and they'll often contact us at the lab and say, hey, you need to add that gene to the panel, you know, because they're on it, so.
And then as well as keep it out of going within yourself and sort of not overcome, because like for me, like, I thought, okay, I've learned about Mito for years and years, and I was like, so then my research like kind of reminded me about criteria for like possible, probable, clear cut, definite. And then it's okay, well, only like say B, like 16 mutations are definite Mito. But then it's sort of like is non-mutation in Mito, would that get considered Mito or like an undiagnosed? So then it's sort of just like you need to do it in a proper way so you don't get your head spinning. But you need to keep the dialogue open between you and yourself and the other basis.
Yeah, yeah.
So-
Communication, data sharing, you know, really is the key to moving this forward. It's not just one person, it's very much a team. It's a team effort, and we all have to work together for that. Labs and clinicians and advocacy organizations together.
Absolutely. I mean, and that's where collaboration, and that's obviously what we've been preaching for years. Collaboration is so important, and not just amongst, you know, your community, but even it may not be the same gene, it may not be the same symptom, but there's commonalities within other rare disease groups. And on that note, you know, I kind of hope all of you take advantage of getting to know your other advocates, because you might, you know, if you start talking, you might find something you connected with that nobody would have thought of. It could be a similar symptom, it could be a similar type of research. Start talking with each other.
Absolutely.
It happened to me that I talked to somebody and they found out Mount Sinai, they've been doing research that they tried to work out with for 3 years.
Welcome to Global Genes. On that note, thank you, Stephanie, very much.